Thank you very much. It's a pleasure to be here to speak on testis cancer as well as radiation. I make the point that this is two separate talks because as it was distributed, it said testicular cancer and the effectiveness of radiation therapy for cancer treatment. And for testis cancer, radiotherapy has a relatively minor role. It does have an important role in a subset of patients, but it's only part of it. So I'm going to give a talk about testis cancer in recognition of the disease being highlighted this month, and then give a little bit of an overview of radiotherapy as a treatment modality. So first off, the anatomy of the testis really drives a lot of the treatment decision, and how we approach it. So the testis embryologically start in the same place as the ovaries do, and then as the male matures, the testis drop through what's referred to as the inguinal canal, the place where hernias form, and then down into the scrotum. So that when we talk about and think about where testis cancer spreads to and how we manage it, it doesn't spread locally, it spreads up higher into the abdomen. So here's the testis that's coming out of the inguinal canal, epididymis at the back, which is has a storage function. And here shows the lymph drainage. When the testis spreads to lymph nodes, testis cancer spreads to lymph nodes, the way most cancers spread to lymph nodes, they spread to the regional lymph nodes, the closest lymph nodes. For testis cancer, those closest lymph nodes are actually quite high up in the abdomen next to the level of the kidneys, because that's where they originally start when they start descending down into the pelvis and then into the scrotum. So when we stage patients, we need to be able to do imaging, even when it's very early, relatively early cancer. That's the primary site we worry about failure. So an overview of the cancer. It's a relatively rare malignancy. It only makes up about 1% of all cancers. But it is the most common cancer in young men from the ages of 15 to 25 to 35. There are very, very high cure rates. And this is an example of a cancer where, with the introduction of systemic therapy, intelligent understanding of the disease, tumor markers, cure rates are, even for very advanced disease, is very high. Early stage disease, close to 100%. Even with metastatic disease, cure rates are in the range of 50 to 80%, depending on the subtypes. The most common presentation is just a painless mass in the testicles. It just can feel like a hard nodule, painless, and other than that, there's often no symptoms. There are some men that can have pain in the testis, and also you can get what's called an epididymitis, which is that thing I pointed out just behind the testis, which has a storage function. It can get inflamed, so it can sometimes be associated with pain, but that's really a secondary effect. The cancer itself, sitting in the testis, doesn't have pain. It's actually the case with most cancers that they don't have pain. It's the secondary effect of it causes inflammation in other tissues. So if there is a solid mass felt in a testicle, then the patient needs an ultrasound. And if it shows itself to be what looks like a solid mass in the testis, then we do markers and then biopsy. And sometimes the only way to do it, to really diagnose this, is to actually remove the testicle. But we only do that if we're pretty certain that it's something abnormal. Risk factors. So men should be examined for this. They should examine themselves when they're showering. They should get this examined as part of their annual physical. But beyond that, there isn't really a need for routine screening through testing, except for perhaps a couple of subsets of patients where there's an increased risk. There's really two main settings. There'll be young boys, when they're infants when they're born, the testis hasn't descended or hasn't descended all the way, and it takes a little bit longer. That keeps them warmer for longer, increases the risk of malignancy. So if a child's had that, then they really should be followed a little bit more closely for testis cancer, and an ultrasound of the testicles annually would be a good idea. In addition, there is a familial relationship. So if there's a family history of testis cancer, then patients or people should have routine screening with ultrasound. But other than that, there really isn't a strong need for screening. Testis tumors, testicle produces, as we all know, produces sperm. Most of that tissue is what's referred to within the testis. There's germ cells, and there's germ cell tumors that form in the testis. They form 95% of testis tumors. There's another 5% that are very rare tumors. They present in the same way in the sense that it's a solid mass, but because it isn't formed from the same type of cellular tissue, we don't really talk about it in the same way we talk about all of the other ones. So 95% of them fall into this. They're broken down into, you don't really need to know this, but they're really two broad categories. I guess if you don't need to know, why am I telling you? I guess you do need to know it. So it's seminoma and non-seminoma. And these are the two main types. Seminomas occur a little bit older in the 30s. It comprises 60% of the tumors. Non-seminomas, which is a sort of a hodgepodge of a few different cell types, occurs in about 30%, and that's in the 20s. Then there can be mixed tumors, which is both the seminoma and the non-seminoma, and that tends to occur in men's early 30s, late 20s, so between the two age groups. So when we evaluate it with this tumor, we need to, as I said, one, we need to understand the extent of disease. So if you have a testis tumor, the testicle needs to be removed. So surgery is really the main part of it. Then when we do evaluations, because it has a tendency to spread, we do CT scans of the abdomen as well as the chest because it can spread to the lung. And in fact, when testis tumor spreads to the lung, it isn't as risky as any other type of cancer that's spread to the lung. Very, very high cure rates even if it's spread to the lung. So we do a CT scan because the first level lymph nodes are in the abdomen, the upper abdomen, at the level of the kidneys. The only way to detect them is through that. A lot of these tumors have elevated blood markers, alpha-fetoprotein, beta-HCG, and then LDH, which is a non-specific marker. Alpha-fetoprotein and beta-HCG are more common in the non-seminomas, and they're a very useful marker. So by using the markers, CT scans, and getting the pathology from the testis, we can stage patients and give a sense of the aggressiveness of the cancer and how we need to approach it. Alpha-fetoprotein may be in either. Beta-HCG is only in non-seminoma. So if someone has that elevated, we know that they have a non-seminoma. And it's important to differentiate between the two because we treat them differently. And the level of the marker affects the stage. So someone has these markers elevated dramatically, it affects how aggressive the cancer is and how we stage it and how we approach it. And what's important about the markers is because these drop off very quickly once the tumor is removed, if someone has an orchiectomy or has their testicle removed, then the markers should drop off very, very fast. And if there's residual markers, we know that there's disease someplace else. And there is a staging that is marker-only positivity, where we can't actually see where any other disease is. We just see the elevated markers. So as I said, the draining lymph nodes are in the abdomen. So we need to make sure we know where those are, and the size of them matters. They can be up to 5 centimeters or more sometimes. They can get quite large quite quickly. And as I said before, lung metastases are less serious than elsewhere. So when we look at metastatic disease in any other cancer, if you have metastatic disease in another cancer, it becomes a stage 4 automatically. With testis cancer, metastatic disease is stage 3. And if it's just in the lung, that's actually a better location with still very high cure rates. So someone that has, especially, these are men in their 20s to 30s, young men, they get told they have lung cancer spread to their lungs. Unless they really hear what's being told to them, they can get very, very despondent and think, oh my God, this is terrible, this is spread. I'm not going to survive this. And in fact, they really will. And there'll be patients that they'll try to avoid treatment because they think, I just don't want to go through that, it's too bad. So they need to know that this is a very, very highly curable cancer. In fact, it's it's a very, very highly curable cancer, and it's really a big success story when it comes to systemic therapy. The chemotherapy has changed these patients from people that would die from their cancer to people that are cured. And it was one of the cancers that when we were treating it, it gave all oncologists the hope that we may be able to have these sorts of magic bullets for a lot of other cancers as well. The staging is stage 3, A, B, or C, which is a combination of metastatic disease and or highly elevated markers. Stage 1A or 1B is node negative and normal markers. Then stage 2 is everything between those two, other than the very advanced and the very early. So I just want to talk about the factors that affect treatment decisions. As I said many times, outcomes are excellent for patients with GCTs, which is a germ cell tumor. The patients tend to be younger, so will live to experience side effects. So if there's a side effect that's not going to manifest itself for 30 or 40 years, well, or more, if you're 25, it's sort of the things we worry about in pediatric case a little, in the sense that they can live long enough to get the side effects. But if you're much older and it's going to take 40 years to experience a side effect, we don't tend to worry about it when we're comparing it to the tremendous benefit of curing something up front. So the question is whether or not, because there's such high cure rates, even when there's metastatic disease, the question is now, how little do we need to do, and how can we follow those patients with the least amount of intervention and still maintain the high cure rates? And just surgery, the point is that they don't go through the scrotum when they're removing it, because that part has never really been affected by the cancer. The cancer descended through the inguinal canal from the abdomen into the scrotum, so it's just an outpouching. Cutting through it, you then contaminate that tissue, so they need to come in down through the same approach that a surgeon would do when they're repairing a hernia. So radiotherapy. So one of the effects of radiotherapy is an increased risk of a second cancer. Now, if the increased risk for someone is 1 or 2%, and you're improving their survival and their cure rates by 10 or 20%, that's a good trade-off. But if you've got someone with a high cure rate cancer and they're in their 30s, and at 40 years there's an increased risk of cancer, which now we've been shown to be about 10 or 12%, that then starts to become a relevant number. So that's driven a move towards what we call surveillance, which is in patients with early stage disease. We still know they have a risk of failing the lymph nodes, but we follow them very carefully with serial CT scans, and then we intervene when we need to. So just to talk a little bit about surveillance, that's important, as I said, because these patients have high cure rates even if the cancer progresses. What is very important with it is you need to have a patient that's very cooperative. They need to make sure they're going to come back for these tests. They come back for the CT scans. Even years later, they can't just get slack about it. And these are young guys who tend to get slack about things. So it's important that we have real strong support with them, that they understand they need to come back for this, because otherwise you can then start to compromise their care if they don't follow it. And so these are the cure rates we're talking about. In seminoma, cure rates with stage 1, which is really often treated with just surgery, overall survival is close to 100%. With surveillance, we have about a 15% relapse rate, and then we salvage, which means we then treat them because the lymph nodes have come back, sometimes with radiotherapy, sometimes with chemotherapy. If with these stage 1 patients we give them radiation or chemotherapy up front, this relapse rate drops to 5%. So you can see why we don't want to radiate 100 people to benefit 10% up front. If we can wait to see which one of those are going to fail and then treat them and still get this very high cure rate, it's an important approach. Stage 2, where they have more advanced disease, it spread to the lymph nodes, the cure rates are still above 95%. In stage 3 with seminoma, and this is people that have had cancer spread to the lung, I've said 85%. It's a little bit lower for patients where they present with the cancer having spread throughout the body to the liver and other structures, but they can still have cure rates of 50 to 60%, even with it being in those critical organs. Non-seminoma is a little bit lower survival for the poor prognosis patients. Stage 1 overall survival. Surveillance is a 30% relapse instead of a 15%. We don't use radiation for non-seminoma. We use radiation for seminoma. We use surgery for non-seminoma. So they open up the patient and they dissect out the lymph nodes in the abdomen. It's a relatively big surgery, and there's nerves that are in there, increased risk of, you can get increased risk of impotence and other problems because the nerves have been dissected out. So we try to avoid it if we can. But if we need to, well, of course, if you can get up to a 99% cure rate, you're going to do that. This is just the overall picture of how we manage these patients. So for seminoma, stage 1, stage 2, and stage 3 and stage 2 is broken out into a little less aggressive and more aggressive. So you can see there, stage 1, we can surveil them, we can give chemotherapy, or we can sometimes give radiation, though mainly surveillance is preferred. With a little bit more aggressive stage 2A or B, we'll give radiation. With aggressive stage 2 or stage 3, we'll give chemotherapy. Non-seminoma has a little bit more complicated treatment, and this just really shows you why it's hard to kind of give just sort of a general overview of exactly how we treat this, because there are steps in the way, decision points, but basically we start from the stage, we do the intervention that we need to. We always try to surveil the earlier it is. The more aggressive it is, we give chemotherapy. It's really in that middle group where they get high cure rates and we try to minimize interventions, that we break it down. So in these patients with the middle group, we do the surgery. Then if there's no lymph nodes, because we don't know that the lymph nodes are involved before we do the surgery. If it's node negative, we don't do anything. If it's node positive, but there's not very many of them, and they're small, we observe. And in the middle, that's actually a typo on it should be node positive, greater than 6 nodes, or any node that's large, then we'll give chemotherapy. So basically, we follow this because we're trying to minimize the intervention and maximize cure rates, and cure rates are very high with this group of patients. I'm going to just go give a little bit of an overview of radiation. I think a lot of people have had an experience with radiotherapy. It's been an effective tool for more than 100 years. More than 60% of patients diagnosed with cancer should receive radiotherapy as part of their treatment. And radiation oncologists are oncologists that specialize in treatment of cancer with radiotherapy. External beam radiation therapy typically delivers radiation using a linear accelerator. And internal radiation therapy, called brachytherapy, involves placing radioactive sources into or near the tumor. We started off just by aiming the beam at an external part of the patient. So we would know where the lung was, where the prostate was, where the breast was, and we would just aim it at the person. So the next step was to use CT scanning to improve the quality of our plans, so we could do a 3-dimensional reconstruction. We'd still take similar plans, but we could reconstruct it against the CT scan and get a better idea where the dose was delivered. So what we do is we use the 3D pictures that you get from a CT scan to do the dose calculations, and then we would put that onto the CT scan. And this is the type of plan you see when what's called 3D conformal radiotherapy, which was a big improvement on the standard radiotherapy. The red is the high dose region, and the green is about 50% of the dose. So we focus it in the middle. It's much like waves coming. They meet in the middle, and they add up to give a higher dose. We give twice as much radiation in the center, treating the prostate, but it still gets these unanatomic shapes like a square in the middle of the pelvis. The next step is what we have now, called intensity modulated radiation therapy, which means that we modulate or vary the dose of radiation through every small bit of tissue that's radiated. It requires the same CT scanning to give us the anatomy, but much more sophisticated computer power in order to do the dose calculations. So it allows us to deliver higher doses to the target and lower doses to the normal tissue. And in fact, the aim of radiotherapy is not so much to hit the cancer, because I think that's pretty easy to do. The main aim of it is to miss normal tissue. And IMRT versus 3D conformal, and we do IMRT here. We have multiple beams, and you can see in the center it's the same relative dosing, but the area that gets 50% is the green area, which is now shaped around it much tighter, and then the blue area, which gets down to 20 to 10% to 5% of the delivered dose, is spread over a much wider area, and that low dose of radiation is much, much safer. And it's so we can raise the dose and increase the cure rates and decrease toxicity all at the same time. I think, just to say very briefly, brachytherapy involves putting radioactive sources into a patient, either seeds that are put into the prostate or a source that's put in using a tube, a catheter that's put into typically a woman for cervix cancer or endometrial cancer. So radiotherapy is used for two main purposes, curative and palliative. Curative is either done as the primary treatment to get rid of the cancer itself, or it's used as adjuvant treatment after surgery. So after the surgeon's removed the bulk of the cancer, radiotherapy is given to get rid of microscopic areas, or it's given to deliver as the primary treatment to treat the cancer itself with or without chemotherapy. A very important treatment is palliative radiotherapy to control symptoms. The treatment process, I'm just going to go through very briefly. With radiation oncology and radiotherapy, we go through the same process. We do a consultation with the patient the way any other oncologist does, make a decision about the part of the body that needs radiotherapy to what dose. That's the clinical consultation. Then we have to go through the process of actually figuring out how to deliver it. So the first step is to do what's called a simulation, which is really what it sounds like, a simulation of the real treatment. So we take a CT scan of the patient. We then import that into a computer system. We do a process where we create a three-dimensional rendering of the patient. We do dose calculations and do a virtual simulation of what the dose is going to be inside the patient. Once we're sure that that's correct, we'd go through a quality assurance step, and then we can actually deliver the radiotherapy. And this is the treatment planning process, which involves the radiation oncologist, radiation therapist, dosimetrists, and medical physicists. This is really quite a complicated process. And sometimes people wonder why, well, you just did the scan, why can't I start this afternoon? Because this is a very complicated process. We do it frequently, we're very comfortable with it, but it doesn't change the fact that it's complicated, and it doesn't change the fact that you want it to be correct 100% of the time for 100% of the patients. It can't be mainly correct most of the time, 100% correct. So we check everything over and over and over again. And we really have the most robust process for quality assurance in my field of any field of medicine. Delivery of radiation, so then the radiation is delivered to the patient. Typically the patient just lays on the bed, no needles, no pain, the radiation is aimed at the patient. It's delivered over a protracted period of time, daily treatments over 3, 5, 8 weeks. We give an incremental dose, and what radiotherapy really does in treating cancer is exploits the difference between normal tissue, so we miss as much normal tissue as possible, but we have to hit some of it because not all the tissue is cancerous. The normal tissue repairs the damage much better than the cancer. So we exploit that difference, and so every day the cancer is maybe 5% more damaged than the normal tissue. You'd give that over a protracted period of time, and you've got to the point where there's a very small likelihood that any cancer survive that. But it does mean the normal tissue has been damaged and it needs to repair itself. Typically, for instance, the chest wall, the skin needs to repair itself, and that takes time, typically 4 to 8 weeks after radiotherapy is finished. Radiotherapy side effects are different than chemotherapy side effects. Radiotherapy is a local treatment. It's aimed at a part of the body, and it affects that part of the body only, except it can cause fatigue in some patients, or most patients. But mainly when you think about side effects of radiotherapy, you think about the part of the body that's treated and what normal tissues are next to it. So for the breast, it's the skin, a little bit of the lung underneath it, maybe possibly the heart, so we do our best to shield out all those structures. For the abdomen, you can get nausea, vomiting. In the pelvis, you can have difficulty urinating, you get diarrhea. In the head, you have hair loss, possibly some headaches, plugged ear sensation. In the mouth, you get a sore mouth. So it's very logical once you think about it. The parts of the body that's radiated get the side effects that you would expect from the tissues being affected. It's an inflammatory process. But the modern techniques, when you think about that square that was treating the pelvis to that very conformed shape treating the prostate, we can now shape around the rectum, decrease the dose to the rectum, decrease the dose to the bladder and the pelvis, and we have much lower side effects from those at a much higher dose. So I just want to talk about palliative radiotherapy. It's a very important thing to understand. Someone that has bone pain, radiotherapy can get rid of the pain completely in half the patients and almost completely in 8 out of 10 patients. It's a very, very effective treatment, much better than being on painkillers, much better than being stuck in the hospital. There are some emergency cases with the spinal cords being compressed. We can radiate that, decrease the likelihood that someone's going to progress to having paralysis from that. Bleeding can also be managed very, very well with radiotherapy. And these are very short courses, anywhere from 1 to 10 days of radiotherapy. So we've talked about this. Primary treatment for cure for prostate and cervix. We can do adjuvant treatment for organ preservation, so larynx and breast, meaning that you can do minimal surgery and still keep those structures, and as palliative treatment to reduce symptoms. Breast cancer, important, is that we can often just remove the lump and then radiate the breast so the woman can keep her breast and doesn't need to have a mastectomy. Now, here we have a lot of women that have the breast cancer gene. In that setting, someone that does carry the breast cancer gene, mastectomy would be indicated, but not all women that have breast cancer here have the breast cancer gene. It's a higher proportion than pretty much any other place in the world, but it still means the majority of women who have breast cancer do not have the breast cancer gene. And those women can be treated with lumpectomy if the tumor isn't too advanced. In addition, when you radiate afterwards, you can improve the cure rates by 10%, which is a very big improvement. Cervix cancer, this is a big thing. We need to be able to detect cervix cancer early. The best way to cure cervix cancer is to detect it early, or even to detect it when there's just cells have just changed and you can just do a cone biopsy, versus having it be more advanced where you need to remove the cervix, the uterus, and do advanced surgery. Plus the cure rates drop dramatically. Cure rates with early disease with surgery alone, over 90%. You drop down to stage 3, which is a very common stage we see. Cure rates drop by half, down to 50%. Stage 4, we still cure some, but it becomes much less common. And I've seen more advanced cervix cancer in the last year and a half than I'd seen in a 20-year practice before that. Prostate cancer. It can be given as the only treatment. Not all men with prostate cancer need to have their prostate removed. Radiotherapy, either with brachytherapy or with radiation, can cure 90% of patients. Radiotherapy plus hormone therapy, we can cure rates of, depending on how advanced it is, a wide range, but we cure a lot of patients, up to 3/4 of them. And then after surgery, if a man has cancer at the edge of where they cut, we should give radiotherapy immediately afterwards. That improves cure rates from about, surgery alone, if it's at the edges, about 2/3 of men are cured. You add radiotherapy afterwards, it's 3/4 of men. So that's a big improvement with postoperative radiotherapy. And we're not seeing as many of those patients as we really should be. So this is my summary. Radiation therapy is well established for the treatment of a number of malignancies. It really should be given to anywhere from half to 60% of all patients with cancer should have radiotherapy at some point during the course of their disease. And it's safe, quick, and painless. Thank you.
At the brink of the hill on East Terrace is the Cancer Caring Center, a comfortable, secure, and tranquil space. This 2-story facility has 10 spacious double occupancy bedrooms, each with an adjoining balcony that overlooks southern New Providence. It's the ideal home away from home for our Family Island patients.
Patients referred by our branches in Abaco, Central, South, North Andros, Cat Island, San Salvador, Luthra, Exuma, and Freeport Grand Bahama, as well as other family islands, receive white glove treatment.
The Caring Center is staffed by a qualified team who exemplify the center's motto, caring and sharing. For more information about the Cancer Society's Cancer Caring Center, call us at 323-4482 or 323-4441.